If anyone is joining late, please help them out with the page numbers. Page number 306, chapter 27, childhood malnutrition, underweight and undernutrition. So underweight and undernutrition, both the issues are included under childhood malnutrition. Usually we now don't use much of this terminology called protein energy malnutrition because it oversimplifies the situation, but it is much more complex. Malnutrition is much more complex. So we now have this approach of identifying underweight children by the weight for age category, and height for age is also another evaluation of height for age. That is also mandatory to identify dwarfing, short stature, stunting. Okay, there are different categories of it: mild, moderate, severe. Okay, that can be identified. Evaluation of weight for height, that is also another important assessment to identify wasting, muscle wasting, or acute malnutrition. So, under the classification of severe acute malnutrition or moderately acute malnutrition, severe acute malnutrition has classification as with edema, that is with swelling or without swelling. Okay, so with edema, if the malnutrition is with edema, it is called kwashiorkor. Okay, and if it is without edema, it is called undernutrition. And weight for the age, if the weight for the age of the child is 80 to 60 to 80% of the normal weight, then it is with edema, it is kwashiorkor. Without edema, it is undernutrition. And if the weight is much less than 60% of the median, okay, that is the weight is less than 3 standard deviations. Okay, so what happens is it is called marasmic kwashiorkor with edema, and without edema, it is called marasmus. So where is the weight for the child depending on its age is very important factor in classifying which particular type of malnutrition the child may be suffering from. So severe acute malnutrition has further classification, and MUAC is mid upper arm circumference. Okay, if it is less than 11 centimeter. Okay, if the mid arm mid upper arm circumference is less than 11 centimeter, and there is edema, and the child's age is more than 6 months. Okay, in this category, if the child has no complications, but malnutrition is there, severe acute malnutrition is there, without any complications, the child may have a good appetite, it appears clinically well. Even if infection is there, it is mild with some antibiotics, it can be treated. Okay, pneumonia, which is not severe pneumonia, if it is there, treated with medication. Diarrhea without dehydration, okay, it comes under outpatient care. No need to admit the child at proper medications, proper food supplements. If it is given to the parents, parents can take care of the child at home. But if the child has complications, severe acute malnutrition with complications, the child has very poor appetite. Okay, clinically, the child appears very unwell, has major infections, severe pneumonia, severe dehydration because of diarrhea. Okay, if all these danger signs are present, okay, like hypothermia, hypoglycemia, okay, if these danger signs are present, you cannot treat the child at home. The child has to be taken into an inpatient care, critical care in a health center. Okay. Nearly 80 million children under the age of 5 suffer from varying degrees of malnutrition even today. And if it is usually it is the girl demographic, large family size, lack of child spacing, family welfare methods, that is unplanned maternity. Okay, these are the situations that has an adverse effect on child survival rate. And other environmental factors like parental education, socioeconomic status, starvation, standard of living, parental attitudes, child rearing practices. Okay, they also influence the growth and development of children. And if there is improper breastfeeding practices early on in the life, Improper complementary feeding practices. Okay, weaning was not done at the right time. Okay, that could also lead to child malnutrition. So malnutrition is generally kind of womb to tomb kind of situation. It may start in the fetal age and it can go up till the last breath of the of a person's life as well. Some micro malnutrition may still exist even if the malnourished child is turning into an adult. Other impact of malnutrition: by the age of 2, the brain attains usually 80% of growth, and myelination becomes also myelination is formation of myelin sheath on the neurons in the brain cells. Okay, that is also almost complete. But if the child is malnourished, okay, what happens is that the growing brain will be affected. The brain will not have enough number of cells, specifically the glial cells. The DNA, RNA, protein, lipids, cholesterol, all these will decrease in the brain during malnutrition. So this is how malnutrition may affect central nervous system growth and development, thus affect lead to mental retardation as well. So malnourished children were found to have statistically significant reduction in serum and cerebrospinal fluid proteins and lipids. Serum trace elements and other macro elements were also found to be quite less in malnourished children when the CSF fluid test was done. Next topics, so coming to the terminologies related to childhood malnutrition. The first is protein calorie malnutrition and protein energy malnutrition, PEM, called PCM and PEM. So PCM, protein calorie malnutrition, it includes all clinical types of malnutrition, but it was later uh, uh, switched with PEM, protein energy malnutrition. So now we use protein energy malnutrition as a terminology. Then PCM. PCM is not used. Protein calorie malnutrition is not used anymore. It is protein energy malnutrition that is used now. Then energy protein malnutrition. So this terminology is used to emphasize the energy gap, not just the protein deficiency. Okay. So energy is given more priority here, not just protein deficiency. It also stresses over the overall energy crisis in mankind as well. So the term energy protein malnutrition is also used by some of the nutritionists to focus more on energy. Protein takes a second priority here. Coming to the spectrum of childhood malnutrition, first is kwashiorkor. So it was first recognized in 1933, and it was contributed to protein deficiency. And usually it was seen that the firstborn child usually used to suffer from kwashiorkor when the second child was on the way. So what happens is that to take care of the pregnancy, the first child is deprived of the breastfeeding and nutrition. Okay, so kwashiorkor, actually it means elder child, okay, in the language of Ghana. So, and later on, the term is used to interpret the disease as deposed child. Deposed child means the child who is not taken care of. And also the color changes in the hair. Okay, that is usually reddish color. So it is called red boy also. In some conditions, a kwashiorkor with where the children have prominent cheek or edema, okay, and it is called sugar baby in in West Indies, the children who suffer from kwashiorkor. So this is the origin of the name. And kwashiorkor has edema, overall edema. Marasmus doesn't. So this distinguishing feature of this severe acute malnutrition is the presence of edema and the rapid demise of these children. And usually in a classic case of kwashiorkor, the child is usually apathetic, miserable. The child is stunted in growth, has edema, suffers from hepatomegaly. Hepatomegaly means enlarged liver, anemia, lack of red blood cells, lack of healthy red blood cells, and hair and skin changes is also seen in kwashiorkor. So these are the symptoms seen in kwashiorkor. Next is marasmus. Marasmus was recognized much more earlier than kwashiorkor, and it is derived from the Greek word called marasmos, which means wasting, because here muscle wasting is seen. Children here exhibit extreme muscle wasting, and they have an old man kind of an appearance. They usually just look like skin and bones. And usually the wasting of the brown fat will occur first because it is metabolically more active, brown adipose tissue. But generally, the children who suffer from marasmus are alert. They have a good appetite, but later on they become irritable. Then we have marasmic kwashiorkor, where children first develop marasmus, okay, and later they develop edema, okay, where marasmic children develop edema, it is called as marasmic kwashiorkor. It will have the clinical features of both marasmus and kwashiorkor. The upper extremities will be extremely thin, skin and bones. Lower extremities will have edema. The ribs of the child will be skin and bones. It will be very prominent, but the abdomen of the child will have edema. Okay, so it will have mixed features. Then we have pre-kwashiorkor. Affected children will have poor nutritional status, and they will again have certain features of kwashiorkor but not complete, like hair changes, moon face, hepatomegaly, okay, but will not have systemic edema all over. Then nutritional stunting or dwarfing. So prolonged malnutrition, okay, which starts at early ages of life, and it lasts longer for overall many years. So these children will develop kwashiorkor or marasmus, and because of which they will have dwarfing. They will not reach up to the height of their peers in the future. They will not have muscle wasting, but they will have stunting. Okay, their height will not grow. And usually, stunting is usually associated with zinc deficiency. Then we have underweight issues when the child is malnourished but do not have any features of marasmus or kwashiorkor, but the child's weight is 60 to 80% of the expected. Okay. Whatever is the normal weight of the expected in that particular age, the child was able to attain only 60 to 80% of that normal weight. Then we have invisible malnutrition. By the name itself, we can understand the clinical features are not very evident here. Okay, toddlers who have breastfeeding, breast milk addiction Okay, you can suspect they may have invisible malnutrition because the breast milk later on is not enough for the child's complete growth and development. Averagely malnourished child, even in the age between 6 to 24 months of age, they completely look entirely normal. Okay, but they are too small for their age. They have low resistance to infection. They fall sick very soon, and they can easily succumb to their illness as well. If the child is getting only 60% of the calorie of what they are supposed to get, okay, in these kind of situation, you can doubt the child may be suffering from invisible malnutrition. Then we have early lactation failure. So again, here, when the breast milk is introduced late, or the child has latching issues, okay, maybe because of the mother's inverted nipples, or the child is not having a strong suckling and swallowing reflex, okay, that could lead to early lactation failure. So because of which other conditions like hypoalbuminemia, less protein, anemia, edema, micronutrient deficiency, they all can be seen, okay. And some mothers, they do not start cow's milk protein, and instead they may give formulas, okay, diluted starch based preparations. In such cases also, the child may have early lactation failure. Even though we have a lot of government initiatives like baby friendly hospital initiatives, breastfeeding policies, but still, uh, we are not able to combat this situation in which young infants are suffering from severe malnutrition. It is commonly seen that when you stop breast milk and introduce ragi by bottle, okay, although the weight recording had shown malnutrition due to the absence of the road to health chart and growth failure, this could not be identified in infants. Then moderate and severe acute malnutrition, MAM and SAM. Moderate acute malnutrition is MAM. So that is also diagnosed using Wellcome method or the presence of edema or mid upper arm circumference. Using this, you can identify what kind of malnutrition the child is suffering from. Coming to the etiology of childhood malnutrition, conditioning influences what causes childhood malnutrition. Conditioning influences, which means low birth weight babies and infections, recurrent infections are the most important conditioning influences responsible for malnutrition. Again and again, if the child is falling sick because of infection, that leads to some level degree of malnutrition, especially in small children. Diarrhea, acute respiratory infection, vaccine preventable diseases like measles, whooping cough, TB, okay, any parasitic infections like helminthiasis. So these are the common infections that can initiate malnutrition and aggravate the existing malnutrition as well. Then certain cultural practices like food habits, customs, beliefs, traditions, religion, cooking practices, child rearing practices, attitudes of parents. Okay, people may tend to consume poor diet. Okay, when even when good ones are available. Thus, the lack of food is not only the problem, but the choice of food that parents make for the children can also lead to problem. Personal likes and dislikes in selection of food. Okay, so these are also called as food fads that could also lead to malnutrition. Then socioeconomic factors like poverty, ignorance, illiteracy, lack of knowledge regarding nutritious food, unhygienic environment practices, large family size, lack of spacing between two kids, unemployment, overcrowding. Okay, so these all are some of the social economic factors related to malnutrition. Then food production and intake. Abruptly, if you withdraw breast milk, okay, there will be a delay and inadequate weaning that may take place. Lack of food supplements that you don't give to the child. Food supplements are available from Anganwadi, primary health care centers as well, for mothers and as well as children. Scarcity of food is a factor responsible for malnutrition at family level, but it is not true at national or global level because there is enough food for all. Okay, but it is other factors, choice of food, starvation, poverty line, these things are determining if the food reaches everyone or not. Okay, accessibility is an issue. Okay, but there is that the scarcity is not an issue. So in India, we can see this dual community where one part of the community is well-fed minority. They have nutritionally better access, and the other extreme is the ill-fed majority. Majority of the Indian population are not fed properly. Okay, even though there is food, they are not fed properly. Then the availability and utilization of health and other services, inadequacies in nutrition and health education, nutritional surveillance is not done properly, nutritional rehabilitation is not done properly for severe acute malnutrition cases, primary healthcare centers are not set up properly or not accessible, immunization, missed immunization. Coming to pathogenesis and adaptations in nutrition. So adaptation in nutrition is a big topic. We will discuss it in next session. But a brief insight regarding adaptation we will do here. So malnourished child, what is adaptation? It is believed that there is a theory that is believed that we believe that a malnourished child will adapt maximum to the unfavorable circumstances. The body adapts to the unfavorable circumstances maximum as possible. And how this is done? It's usually you can compare this situation to hibernation animals. Okay, in the winter months, in the cold months, animals go into a state of hibernation. Okay, they hide themselves, they forage their food and hide themselves for months together. And after, when the cold is gone, in during the springtime, they may the animals who went into hibernation will emerge back again. Okay, so similar situation is seen in children as well. Hibernation is, as I explained, animals go into hibernation during cold months. Okay, cold months it is difficult, specifically in the regions where snowfall is there. Okay, majority of the livestock, okay, they all go into hibernation. They don't step out of their homes. Okay, even in woods or forest, wherever they are staying, the animals you find, they go into hibernation. They collect their food, they store it for months together, and they feed in that. The entire family of the animals stay together and feed on that collected foraged food. Okay, and after the winter months are done, cold months are done, these animals will emerge back again. Okay, so what happens in hibernation is that when we compare the same hibernation in malnourished children, what these children do, they reduce their activity, they reduce their growth. Okay, they stop their growth, they can bring down their basal metabolic rate, so that the body is able to save energy just to survive. Okay, in hibernation also the same thing happens. The animals just sleep, they don't do any activity, they just sleep throughout these cold months. Okay, eat and sleep, and they don't do any activity, so they're saving their energy. Okay, So in a malnourished child, due to associated diarrhea, because diarrhea is seen, okay, that is the only thing that is different from a malnourished child and a normal child. Other every aspects, the child is trying to save energy, okay, save the nutrients, but only because of diarrhea, the fecal loss is much more than a normal child. Okay. Protein rich food, even if it is advised, it will increase the protein levels in the child immediately. But when you increase the carbohydrate rich food, that will increase slowly. Okay. And this adaptation in malnutrition is basically biochemical and hormonal as well. And the high level catabolic hormones, including cortisol, also cause fat, muscle, and fat breakouts. What happens in hibernation? The same thing happens here in children as well. The child's own body is trying to break its own fat and protein to provide energy and supply energy for survival of the child. The same thing happens in animals as well who go into a hibernation. Their own body goes into a state of catabolism. Catabolism means the body will break down its own protein, muscle, fat to feed itself. Okay. So the same thing happens in these malnourished children as well. Now, the other question is, why do some children develop marasmus and why some other children develop kwashiorkor? Okay. So, first cause is variable calorie and protein intake. The amount of calorie that they take, the amount of protein that they take is completely different. Usually, protein deficiency was thought to be because of was the cause of kwashiorkor, and predominant calorie deficiency is the cause of marasmus. Because of protein deficiency, you get kwashiorkor. Because of calorie deficiency, you get marasmus. This was what we thought earlier. Okay, protein deficiency in experimental animals, when in laboratory, some experiment on animals was done. Okay, it has shown that some a syndrome similar to kwashiorkor took place, but later later this information had emerged that for both the syndromes that occur in children, okay, they take similar diet. Sometimes both occur in the same family among siblings as well. Those who are taking the same diet, okay, those who are taking the same calories, same protein, but one child may suffer from kwashiorkor, the other child may suffer from marasmus. Then time-bound development of kwashiorkor and marasmus. In 1964, it was suggested that time is a determining factor. If malnutrition is chronic, the children may take the long marasmic route and adapt. If it is acute, they may take kwashiorkor route and fail to adapt to the situation. That's why in kwashiorkor, that death rate is quite high among children. And if from a very young age it is starting, so it starts into marasmus, but after certain age, after 3 years or so, if the child is suffering from malnutrition, it may lead to kwashiorkor. Then we have the theory of adaptation. This is a theory, not the truth. Okay, so it is theorized that if the child adapts to malnutrition, marasmus results, and if the child is not adapting to malnutrition, the child goes into kwashiorkor. Okay, because when adaptation is taking place, we have seen that body goes into a state of catabolism, in which body breaks its own self, catabolysis, its own muscle, protein, fat to feed itself. That's the reason why marasmic child are so thin. They're just skin and bones. Okay, but in kwashiorkor, if you see, the child is not thin, the child is heavy, the child has edema. Catabolism is not taking place, which means the child's body is not adapting to malnutrition. Okay. So in adaptation, if the child's body is able to adapt, the child suffers from marasmus. If the child's body is not adapting, the child will suffer from kwashiorkor. Then we have the Golden's theory of free radical, which it postulates that whatever radical damage takes place, if it that is the reason why skin changes, fatty liver, okay, takes place. This is what Michael Golden has said about free radicals. Okay, free radicals are the culprits here that leads to skin changes and fatty liver. So these are the four different reasons and theories that says that why do certain children suffer from marasmus and why other children suffer from kwashiorkor. So adaptations in detail, there are different forms of adaptations we will learn in next session. If you have any queries regarding this, please mention in the chat box.